So I'm going to try and do all of this tonight, but obviously tailor it to what your needs are. Okay. Is anyone aware there was a new NICE guideline out in June, NG 98? This covers some aspects of hearing loss, and there is a section for earwax removal, so it'd be worth you all having a look at that. Interestingly, on that NICE guideline, it states that you should use softeners for about 5 days before irrigation, and only attempt 2 attempts and then refer. So it'd be worth, you don't have to read the whole guideline, but it'd be really worth looking at that. So hearing loss is really common, and this is a true saying from Helen Keller. She was a famous person who was blind and deaf. If you're blind, it cuts you off from things, but if you're deaf, it cuts you off from other people. And if your only source of enjoyment is telephone, radio, TV, and you can't hear, then quickly that leads to social isolation, depression, and loneliness, which is hard when you're elderly anyway. So prompt referral is vital. Oh, hang on, is that not? Have I done something? I think it's because that's come on. No, don't go. Oh, right, okay. Go back. Oh, we're stuck. Right, okay. So when you think of the ear, think of it holistically. Can anyone give me any ideas of conditions that would affect the ear? Skin condition? Eczema, psoriasis, that's right. Trauma, infection.
Cholesterol.
Yes, cholesterol, high cholesterol. So don't just think of it as an appendage on the side of your head. It can have trauma. Think of rugby players, boxers. Quick reversion of the anatomy of the ear. So, any offers for here? External auditory meatus or ear canal, because it's important to speak to language in the language your patients understand, as well as knowing the proper. But if you're just writing in notes, you can just write EAM. That's quite acceptable. Okay. In the average adult, it's not straight, and it's about 25 millimeters long, lined with epithelium, like the rest of our body. And when you examine with an otoscope, it's very important to get hold of the pinna and just straighten the external auditory meatus. Otherwise, if you put your otoscope in, all you're going to look at is the wall of the meatus, and you won't see the tympanic membrane. Also, where this skin over bone here is a very common place for trauma, so when you're putting an otoscope into the ear, be very gentle, because that's where you can scrape. So we'll progress. Ceruminous glands are right at the beginning of the ear, and then going down the ear. Any offers? Tympanic membrane. Tympanic membrane is angled towards you at about sort of 60 degrees, and if you notice, there's a little dip just before the tympanic membrane. So when your patients are using their car keys, matchsticks, whatever, to stick in their ear, they're pushing their wax down into this nice little dip in front of the tympanic membrane. Copperbuds. Yeah. So from the tympanic membrane to the pinna, which is the outer of the ear, that's the external ear. And then we move into the middle ear. There's 3 little bones there, called the ossicles, and they're known as the malleus, incus, and stapes. And these little bones are the same size when you're born as when you die. And they're joined with little synovial joints so that they move as the sound wave hits the tympanic membrane. Coming off the middle ear is another eustachian tube. Excellent. That's lined with ciliated epithelium, and it wafts the mucus from the middle ear down into your eustachian tube, and you swallow it. You're totally unaware of the function of your eustachian tube unless you have a heavy cold, hay fever, anything that blocks it, and then you can't equalise your ears. So moving from the middle ear, we go to the inner ear, and there's the semicircular canals, which are nothing to do with the mechanism of hearing. They control your balance. And then the cochlea, the round window, and the 8th cranial nerve, the auditory nerve, which has a vestibular and cochlear branch. And if you look here, this is bone above here, and above the bone is your brain. So when your patients are putting sharp objects into their ear and they slip, they're very close to the brain. So really important to advise them never to put anything in their ear smaller than their elbow. And even the NICE guidelines does mention about advice to your patients. The nerves associated with the ear are the 7th cranial nerve, which is your facial nerve. And if anyone has seen a Bell's palsy, you'll know the effect. Or if you have an injection at the dentist, that's the nerve they inject. The chorda tympani is a branch of that facial nerve, and that sometimes in children's ear, when it's really clear, you will see that through the tympanic membrane. The auditory nerve and the vagus nerve is the 10th cranial nerve, and that you can sometimes stimulate when you're either your water is too cold for irrigation, or it's just the position, and the patient will start to cough or feel a bit peculiar. And if that happens to you, just stop, get them to focus on something ahead, move the angle of check your water temperature, and try again. And usually that resolves it. So the pinna, when you hold the ear, please try and hold it by the concha. And if you bring it out and up in an adult, and out and down in a child up to the age of about 10, you'll get a good angle then. Any area nowadays can be pierced, and you can get infections through the pinna, below the tragus. And the function is to funnel the sound waves into your ear. So a normal ear canal should have a nice healthy rim of wax, and you see the new goblets just forming on the hairs, and that's a healthy ear. Wax is formed of ceruminous cerumen, rather. It's a sweat-like substance. Sebum from the sebaceous glands, epithelial migration, so skin that's just shedding, and dust, hairs, foreign bodies. And what's its function? Protection, lubrication, and it's slightly pH acidic, so it's slightly bactericidal. Okay? I'm whizzing through this, but any questions, just shout. And things that affect your wax. Diet, people with high lipid levels often have quite sticky wax. Aging, anatomy, genetics, itching. If you think about it, the ceruminous glands are right at the beginning of the ear canal. So if you're a sort of nervous person that itches, you're stimulating them all the time, encouraging your ear to produce more wax. Aging, everything slows up as one ages, so your wax doesn't, it dries out and it doesn't move as fast because the epithelial migration isn't as quick. if you've got very narrow ear canals, it's a huge problem. And some patients with very narrow ear canals, really microsuction is the best option for clearing their wax. Because the wax gets stuck in the ear canal and is really resistant to move. So that's a picture of soft wax, and if you look at that, does anyone think that needs irrigating? No, because you've got the tympanic membrane visible. So sound waves can come in and hit the tympanic membrane and a mechanism of hearing can go ahead. However, if that person is going to Specsavers for audiology tomorrow, every scrap of wax needs to be removed. And even if they've just got this little rim of wax, because they will do a mould fitting, and if there's wax in the ear, the mould won't be correct, and then their hearing aid will whistle. So, which gives practice nurses a huge workload. I'm not sure how things are here, but certainly down in Sussex, the GPs are not paid for wax clearance. They don't earn cough points. So some surgeries are refusing to do it. Some surgeries have got microsuction equipment, and GPs are paid in Sussex for microsuction, so they'll offer microsuction appointments if they've got the equipment. But you obviously need training for that, and you need a room for a couch, and it's quite big, microsuction. Does anyone do microsuction here? No.
Do you train people to do it?
Yes, I'm trained to do it, and Rotherham run I did a 2-day course, but it's now, I think they can do it in 1 day now. Yeah, it's becoming more and more common. But I think it's all finance driven.
Yes.
It's not what's best for your patient. So most of your ears that come to surgery are like this, and you can see the difference between the young wax, which is healthy, and this wax, which it's well oiled because it's glistening, but it's been sitting there a long time and it's completely occluding. And people with ears like this, if they get water stuck behind that wax, that can be a real problem and give them an otitis externa. Does anyone recognise what that might be?
Melanoma.
No, actually, it is impacted wax by a cotton bud. That's a dent there, and that's all the fragments off the cotton bud. Where they've been going around like that, pushing it in, they've packed it down onto the eardrum. So please, I wish they'd never been invented, but please encourage your patients not to use them. The cheap ones, the ends come off and they get stuck in the ear. It's horrible. So, going to the middle ear, the tympanic membrane. When you're looking at an ear, you're aiming to view the tympanic membrane, and you want to know, is that tympanic membrane intact, and be able to recognise the key features. Unless you can see all of these features, you shouldn't be documenting in notes that it's normal. So quickly revising this is a left ear, and you've got the pars flaccida at the top, which is not quite as taut as the pars tensa. Your otoscope light will give you a light reflex just on the ear there. And then you need to check the whole rim to make sure there's no perforations. You'll see the handle of malleus, which is attached to the back of the tympanic membrane, and the lateral process there. So that's a real ear, and that's your diagram. So you see the light reflex, the lateral process. No two ears are the same, and I reckon until you've looked in about 100, you can't feel really confident of what you're looking at. And even then, some ears are very strange. So, which ear is that?
Right.
Yes, and that's the light reflex. A very clear tympanic membrane. You can almost see through it into the. In fact, you can. That is the eustachian tube on the other side of the tympanic membrane. So the tympanic membrane is covered in epithelium, and it's all right.
Yeah.
Yes. That's your tympanic membrane, your Handler Mallis Latin process. The epithelium starts growing in this sort of area here. It's called the umbo, and it comes out and grows across the tympanic membrane. The epithelium sheds. Your ear there. This is my ear canal. A few hairs at the entrance. The epithelium sheds in a circular motion, in a spiral, on down, and comes out of the ear. And that whole process from this little black dot to the outside of the ear, which is only 25 millimetres, takes about a year. So if you're disrupting that by pushing cotton buds down your ear, your epithelium is going to get pushed back down, mixed up with the wax. And it migrates, as I say, that's the same dot, and it's come to the outside. Otoscope. You need to hold your otoscope in the, just like you would a pen. So if you write like that, and ideally, right hand, right ear, left hand, left ear. Make sure you have good bright batteries, and then you get a much better view. I also have you get what you pay for with otoscopes, but for teaching I also have an iPhone otoscope, which you made by Cupris, and if you are looking at ears and then wanting to send a report or something, it's a really good. So
How much is that?
it's about £100, not with, obviously you've got to buy the phone.
Oh, no, but that.
But it's really good. You imagine if you're in a third world country, you're doing a remote clinic,
Yeah.
you can contact,
Second opinion.
yeah, and then you can keep your pictures of your ears.
I'm describing it.
Yeah.
So that was a student, a very young student with a lovely clear ear that at the Hearts Uni I have another wire that fixes up, so the whole class look at their ears, and but the only thing I was saying is that this company developed these, and then I don't think they were quick enough to get them for Android as well, so I can give you details of iPhone, but I don't know whether they were quick enough to get them for Android as well. So when you're using your otoscope, make sure you pull the ear out and up and then gently insert it, and then have your finger resting against the patient's face so that if they jerk, that will prevent you scraping the skin because these are quite sharp. And make sure you've got the right brand of speculae for the otoscope you have. Unfortunately, they're all different. If you can have one size for adults and one size for kids, that's great. I know some surgeries, they just get you one size. What you're looking at is the tympanic membrane, and your main concern is, has this person got a perforation? So the external ear, as we know, has got the epithelium, then you've got a fibrous layer which gives the tympanic membrane the strength, and the middle ear is lined in a mucoid layer. When you have a perforation, it goes through all three layers. Can you think of reasons for perforation? Trauma, yeah. Infection, that's right. Loud noise, like a bomb blast will do it. Yeah. When your ear heals, and that takes 6 to 8 weeks in an average adult, a child might be slightly quicker, you never get the same strength because the fibrous layer doesn't heal. So you then have just the epithelium and the mucoid layer. If you have somebody who has recurrent infections, you're going to end up with a chronic or old perforation, and instead of looking like you've put your fist through a drum, you get a nice, neat little edges, and that perforation will never heal and seeps from time to time. I'm sure once in your working life you will irrigate an ear that's got a perforation, but hopefully you'll only do it the once. Safe and unsafe perforations. Because, as I explained, the epithelium grows from this central area, if you have a central perforation like this, pretty soon the epithelium is going to cover over that and repair. And epithelial migration, which occurs from the rim, will carry on. If you have an unsafe perforation, your epithelial migration happens and the epithelium and debris drop down into the middle ear rather than carrying on out the external auditory meatus. The concern is that with time, as debris builds up in the middle ear, it develops into a cholesteatoma. And basically this is a collection of keratin debris that decomposes and erodes with time into the middle ear. And it can cause a serious amount of damage. My youngest son had one about 4 years ago, and it's pretty major surgery. That's a traumatic perforation, obviously taken in theatre because it's very neat. You can see all the skin flaps there. Mostly when somebody comes into the surgery with one, it'll just be blood coming out of the ear and you can't see exactly. I used to always bring them back in 6 weeks' time to check that it had healed and hadn't left a chronic perforation. So that's a safe central perforation. Tympanosclerosis is this white shading you see on tympanic membranes, and it's usually like calcium deposits from recurrent infections as a child. Quite common to see that on ears. That's a healed perforation. Can you see here? It was a big perforation, but it's healed over, but it's a lot, it's not as strong as the rest of the tympanic membrane. So, and hopefully you won't see anything like this in general practice, but you definitely wouldn't irrigate an ear like that. So it's subtotal, and that's not going to hit. You haven't got any edge there, so you're not going to get that healing. And then a total perforation. You've got the cochlea as your malleus, and these are the goblet cells lining the middle ear, which produce the mucus. So how would you know if somebody had a cholesteatoma? The most common thing is an intermittent smelly discharge. You've got that debris just breaking down in the middle ear, eroding the malleus incus. They get a conductive hearing loss because the little ossicles cannot move because of the debris in the middle ear. And then they make a feeling of heaviness and discomfort because the branches of the facial nerve begin to be affected. Pain, a palsy, altered taste, tinnitus, and dizziness. And they may have one or all of those symptoms, and they need referring urgently. And what you might see is wax crusting, a sort of breadcrumby appearance. I don't think you see a retraction pocket or marginal perforation because there's too much debris in the ear.
How
But
urgent is urgent referral? Because there's a long waiting list for ENT.
there is. I
50-something.
can only speak from a mother's point of view, and I referred one young lad with one, and did it under, urgent referral, and he had his op in about 6 months.
That's not urgent.
No. With my son, I'm afraid
It's the same everywhere.
he gave up,
Well,
went
that's
privately.
the country, and it's a long way.
because he couldn't drink. His mouth wouldn't function properly, and the pain. He couldn't get to work. So,
Would you recommend they go private?
well, no, I can't be recommending that, but yes, an urgent referral for ENT sometimes isn't that urgent. Well, that's how it is in Sussex, and obviously it's
No,
same here.
it's well.
But ideally.
You see, it's very slow growing. That's the thing. It's very slow.
Right.
I mean, my sons, they reckon, he had grommets about age 10 and 12, and then after that, they reckon it started forming after that. Yeah. So, I put this slide up because you can see how close the brain is to the top of the middle ear. And particularly if you have a cholesteatoma, what happens is it destroys the malleus and the incus, and then it starts to eat through this temporal bone and then into the brain. So very serious. And also for stopping your patients putting sharp things in their ears, it's very dangerous. Well, that's why. And even if you're a complete novice and looking in ears, if you looked in an ear that looked like that, you would know it wasn't right to call in the GP, wouldn't you? Combined with the smelly discharge. Yeah. Oh, that's another one there. That's a little polyp growing there. But again, it's unrecognisable. And there's another one. You've got a perforation there, and you can see all the debris. There's your lateral process. That's all you can really recognise.
If you did see it and then you complain of pain, because it's quite an urgent
Yes.
matter, would you refer them to A&E?
I would. You all work in surgeries, don't
Yeah.
you? So I would just get a GP and say, I'm not happy with this. It needs an urgent referral. Yeah. Don't let them just give them drops. No. So, external ear, middle ear, and then you come to the inner ear. This is quite a, I'm jumping the gun a bit. Middle ear mucosa. That is an enlarged goblet cell, and that's what lines the middle ear. Okay? Pressure effects on the ear. Your ear functions really well when you've got positive pressure in the external ear and the middle ear. If something upsets that and you get a negative pressure, like for instance if your eustachian tube is blocked and you get onto an aeroplane, you'll get negative pressure in your middle ear and pain. And you can see what's happened to your nice taut tympanic membrane. It's been sucked, indrawn inwards. And you'll get that with negative pressure in the middle ear, and it's what happens to children when they've got blue ear and their hearing is reduced. You can get a reversed ear, or that you can't see it, if your patient is going on holiday with an ear that's totally blocked with wax. What happens then as the plane takes off, the tympanic membrane becomes sort of convex, and they get negative pressure behind the wax, which also gives them pain. And that's why a lot of patients come in saying, I need my ears doing, I'm going on holiday next week. They expect you to magic up an appointment. So, but it's very, very uncomfortable. And this is what happens to the eardrum, the tympanic membrane. As that plane ascends or descends, you get little tiny hemorrhages into the tympanic membrane called otitic barotrauma. And it will resolve, but that's what it causes, because it's just sucked violently inwards. And if divers descend too quick, that's what happens to their ears. I've put this slide in because it's a picture of a grommet. These are tiny little tubes that children have put in their ears when they have persistent glue ear and caused by the negative pressure in the middle ear. And all surgeons will put it in a safe central location, and as the child grows it just pops out on its own, and but never ever pull one out, even if you think it's just in the ear canal, because it's got a back on it just like that, and you would cause trauma. Let it just come out naturally. No. A few adults have them and they're permanent and they're sutured into place, and they're usually almost the colour of these chairs then. This looks similar. But. So if we go into the inner ear, the cochlea was that, cochlea was this structure here. If we unravel that and cut a section through it, cross section, it's predominantly made up of perilymph, which is sodium, and endolymph, which is potassium. And this is why sometimes you'll get a problem with patients who are on strong diuretics. If their electrolytes are out of kilter, that can affect their hearing. And what happens, as the sound wave is funneled down the ear, it bounces onto the tympanic membrane, it moves the three little ossicles, and the stapes is attached to the cochlea at the oval window, and that then makes the fluid in the inner ear shimmer. And as it moves, it stimulates these little hair cells which are under the tectorial membrane. And the hair cells detect different sound frequencies. And it's a very complicated system, but these are the hair cells that get damaged when you're exposed to too loud a noise. That's what you get ringing in your ears. Noise levels are described in decibels, and really I'm probably speaking round about now about 65 decibels. Average sort of heavy truck going through the street be 88 decibels. And for every increase in 3, you can tolerate 4 hours at 88 decibels without any damage to your hair cells. That every increase in 3 decibels, that time reduces. So that by the time you're at a pop concert, 1.5 minutes before you've got some damage to your hair cells. So that's why the next day you have ringing in your ears, and hopefully if you're not doing that every day, they recover.
Oh, good.
People who do noisy jobs, who work at, say, airports or whatever, are provided with ear defenders.
Can I ask you a question? What
Yes.
are these people who wear these big for radio and the phones?
Yes.
These big,
I think we're going to have a real problem because a lot of them wear in-ear headphones. The wax can't escape. Their in-ear headphones are in.
And now you see these very big ones that go
pricked. They're probably better
Yeah.
for their ear than the in-ear ones.
I agree. No, they're all
Because those, that some kids have got them in virtually, 12 hours a day. The wax can't escape, so they're cranking up the volume, which is then giving them hearing loss as well. So yes, this is going to be a problem, I think.
Can they cause ear infections as well?
The in-ear, yeah, I mean, if you've got itchy ears
Yeah.
and you've got a little break in the skin and you're keep putting in dirty headphones, sure.
They don't clean them, do they?
Otitis externa. Yeah, it is a problem. And if you're doing an occupation where you are provided with good ear defenders, you must wear them, because if you don't wear them and then try to sue your employer, you won't have a leg defence. And you'll see people digging up roads with them round their necks. So, I'm galloping through this because this is a quick update. The equipment you need for ear irrigation is, and I'll tell you what, I've forgotten my headlight. But how, most of you using a Propulse irrigator. Have you got the NG, which is the green one, green and silver one? Or have you got the G5?
But the purple one.
Oh, the purple one. Oh, very modern. This is the Propulse 217. That's the G5. Has anyone got, this is really solid, this one, a Project? No. This is the latest model, and the G5 came after the green one. Yeah. So you need everything that possibly can be disposable needs to be disposable, because in the old days we reused the tips. And in 2004, Propulse did a study. They took 40 patients with hepatitis B, and they took all the Propulse tips and tested them, and 27% had hepatitis B virus in the tip of the Propulse. And when I was a district nurse, we used to just soak these and reuse them. So overnight they banned disposable tips.
The old metal
You need to use disposable Jobson horn probes, which then go and fill up landfill, but that's the way we've gone. But I like these carbon curettes. These are really good, I think, for we've got the wax hook at the end and then the serrated bit for Jobson horn probe.
I thought we weren't allowed to use them.
Yes, no, because if you're doing instrumentation, that's all you do use. Yeah.
That's what I thought,
It's very important to dry.
to use them. Yeah, because you could perfectly.
Well, the idea is that you dry the ear after it's been irrigated. So if you leave an ear wet, you're going to leave the patient open to otitis externa. Don't bother buying a cape or reusing a cape. Just use disposable apron, put it, tie it, and then throw it away afterwards. Okay. And are you all using disposable Newts receivers?
Yeah.
Yeah, brilliant. So anything else? And if you can wear a headlight, it's much better view than without. Decontamination needs to be done every day before you use the irrigator, and you need either a Propulse tablet or Chlor-Clean. Make it up to the directions on your specific brand, but basically anything that's makes up a solution. I think it's 1,000 parts per million of NADCC. Gosh, and never inhale this stuff. It's making me cough. Holding that stuff. Window open. Protect yourself. Apron, gloves. They don't say to wear goggles, interestingly, but
It would be sensible.
the girls at Rotherham have lung function tests every year because they're doing this every day and lots of, yeah.
Lung function test.
Yes, because it does, it makes you cough. So, make up your solution, allow it to dissolve. That tablet will take about 6-7 minutes to dissolve. Pour it into the water tank, up to 500 mils. Run it through to the tip of your irrigator here, because the tubing is where the Pseudomonas will grow. Leave it for 10 minutes and then empty it out. If you've got this P5, this has a timer on here, and it will send an alarm at the end of 10 minutes. I don't know why they've taken that off, and then this model they've just brought out hasn't got it. And this model also can't be used, not plugged into the mains. Whereas this one and the NG were better, because you could, especially if you're a district nurse, you could use it without having to have a plug. After that 10 minutes is up, empty the tank and tubing out and flush it through with cold water, and you're ready to go. Okay? So, this is the one most of you have got, I think. Yeah. Okay, that will run off battery for 10 minutes, which you can do a lot of ears in 10 minutes. So, headlight, newts. This isn't essential. Crocodile forceps. This is very handy, but not essential. Okay?
But you can't see otherwise.
So you can see, if you're looking at an ear with a headlight, you've got a much better view. And if you're a district nurse in poor lighting, it's essential. This is the model before the NG, but you need to be pointing the propulse uphill and the tip towards the crown of the head. You see? So in it's a right ear, that's at 11 o'clock. In a left ear, 1 o'clock. Okay? You don't need to move the tip around, you just leave it pointing at the posterior wall. The idea is the water will push down the posterior wall, round the back of the wax and flush out into your newts receiver. And what temperature should your water be? 37, that's right. Some patients just prefer it slightly warmer, but if you use it too cold, you can make them feel quite peculiar and they can get a bradycardia and feel quite faint. Yeah. So contraindications to irrigation. This is best to discuss with the patient when they first sit in your room, and then you can make sure that you haven't got any. I have them written out on a laminate that I keep in the treatment room. So basically, anyone who's had complications in the past, because they will have, if they fainted, they'll have blocked your room, and it caused a real problem for you for the rest of the morning. So if that's been a problem, I would refer them. A history of a middle ear infection in the last 6 weeks. And that's because the tympanic membrane will have been really stretched with the infection. They may possibly have had a small perforation and you wouldn't know. So anyone who's had a middle ear infection in the last 6 weeks, don't do it. Anybody who has ear surgery, apart from grommets, which have been extruded at least 18 months ago, and it needs to be documented in their notes that the grommets are out and the tympanic membrane's intact. Anybody with a known perforation, because otherwise you're going to fill up their middle ear with tap water, and our tap water is not perfect, it has Pseudomonas in it, very often. A history of a mucus discharge in the last year. Why do you think that? If they've had a mucus discharge, they must have had a perforation, because it only can come from the middle ear. An acute otitis externa with pain and tenderness of the pinna. Does everybody know what an otitis externa is? Basically, an infection in the external ear in front of the tympanic membrane. Very common in swimmers, often known as swimmer's ear. Very common in people who have eczema in the ear. Special precautions. That means you could go ahead, but you must have the irrigator on the lowest pressure for people who've had a known healed perforation, a cleft palate which has been repaired or not, tinnitus or dizziness, or are taking anticoagulants. Because when the wax comes away from the ear, sometimes it breaks off a little bit of epithelium and you sometimes get a little bleed. And if they're on anticoagulants, that will be more significant. It's nothing to worry about, you just need to get your Jobson horn probe with a little bit of cotton wool wound around the serrated end and just press on the area that's bleeding. And tell your patients if there is a bleed. Don't let them go home, because if they get home and find they've got dried blood coming out their ear, they'll be straight on the phone to the surgery saying, well, that new nurse has perforated my ear. If you tell a patient, if they're well informed, and you explain why it's happened, then they'll be fine. Okay? Guidelines for records and record keeping. This is for anything in your nursing life. Your quality of your record keeping is a reflection of the standard of your professional practice. If you didn't write it down in a court of law, you haven't done it. So you need to make sure that your records are tip-top. And this is what you need to put down. You've probably got, have you got System 1 here? No, EMIS. You should be able to get somebody to do you a template and then consent obtained. The fact the patient's sitting there wrapped in an apron and ready for you, oiled their ears, that's consent. They don't have to write their consent. Whether it's the right or left ear, that you don't have to write it in such fancy language, but you can put both ears totally occluded with wax, or left ear, whichever ear you're doing. No contraindications to irrigation, which means you've gone through with the patient all the contraindications and they, to their best ability, have assured you there's none. Both ears irrigated and clear, or left ear irrigated and clear, right remains blocked, advised to re-oil and come back next week, whatever has happened. And the most important thing, drying, both external auditory meatus dry mocked. Even if you're not using a Jobson Horn probe to dry the ear, corner of a tissue will act as blotting paper if you're nervous of using an instrument. But the worst thing you can do is send them out with wet ears. And advise your patients to keep them dry for at least 2 days. And then the most important thing, both tympanic membranes intact with normal features. If you haven't documented that, if there was a case against you in future years, then that would be problematic. If you've documented that both tympanic membranes are intact with normal features, there's no court in the land that would go against you. Okay. If you don't write it down, you haven't done it. And the advice given, so you're going to tell them to keep their ears dry, report if they've got any pain or irritation in the next week, not to put anything in their ear smaller than their elbow, and if it's an ongoing problem, maybe to try using something like ear oil once a week. This is quite handy for patients who are not very dexterous. It's olive oil in a little spray, and they just spurt some olive oil into their ear. If they just did that once a week, it might stop their wax drying out, remaining stationary, and it might encourage natural wax migration. Ear oil do another one called Swim with tea tree oil. So for people who swim a lot and get otitis externa, sometimes that can help.
Is that a spray as well?
That's a spray. Yes, that's a spray as well. Yeah. Prefer them not to use Otex. It's hydrogen peroxide. It can cause a lot of irritation in the ear. Yeah. Don't let your patients buy this. It's saline in a spray. £9, waste of money. And what's more scary is ear syringe. If I can buy that on the internet, they can. This is an ear syringe. Your patients will call it ear syringing, and that's why. Can you still buy it? Yeah? They've got £14 on the internet.
I thought it was bad.
It's bad. And this nozzle is longer than the external auditory meatus. And I'm not kidding you, if I fill that with water, it will hit backward.
You get
The
perforation.
perforation as well.
And now you've been selling yours on Amazon again.
Sorry?
Poppy
candles?
No, they don't. They don't soften wax. They might make you feel relaxed. But
Candles.
hobby candles. Yes, I've got some somewhere. They're such scented candles people put in their ears, thinking it will remove the wax. It may warm it up a bit.
What about ear bulbs? Ear bulbs.
Well, that's what you get with Otex. No. One of these
Oh.
comes with the Otex. You use this for a few days and then do self-irrigation. No, because people can puncture their teeth all over that. Yeah. I wouldn't recommend it.
There's something
not.
on microsuction I saw in the chemist.
Oh.
Yes. The patient brought it in,
Yes.
and it's a bit like that one.
Yes.
It sort of sits on it. It's shorter than what you're
Yes.
showing. And it's like, it's.
Oh, I haven't seen that one. I've
Oh,
seen
I'm
something
not
else, a
sure.
bit like a hairdryer that's supposed to suck.
Yeah, it's sort of.
Yeah,
a
but the
little
end piece
suction.
got stuck in the patient's ears.
So I'm not sure about that.
Right. Any questions?
Interesting.
If you want any equipment or these laminates, they can be ordered from Rotherham. They also do a excessive wax clip sort of flow chart, so you can make a decision, decide what to do. They sell most of the equipment if you are having problems getting hold of equipment, and the website is fantastic. If you just Google Rotherham Ear Care, it'll come up. And they used to have the Ear Care guidance document in 2014. This was replaced by separate guidelines. So you've got otoscopy, ear irrigation, microsuction, oral toilet, and if you just go onto their website, go under, I think it's healthcare professionals, then all the protocols will come up and you can just print them off, okay? And equipment order forms, all on the website. If you've done the course, you can print any of their leaflets off as well, which are handy.
Can I just ask what age would you go down to? Sometimes we get asked to do like 12, 13-year-olds.
Yes, I mean, you can do a 12, 13-year-old. It really depends on how composed and calm the child is. If you've got an 8-year-old who's used to going to ENT, used to somebody looking in their ear with an otoscope, they're going to sit nice and still and behave. But if you've got a child that's never, they'll be frightened and you need to refer them. So there isn't actually a set. No. We really only recommend olive oil for...
Because a lot of the doctors still give sodium bicarb.
Exactly, and there's a prescription cost. Most people have got olive oil in their cupboards, just room temperature.
The problem with it, sometimes the olive oil, because it's absorbed, that it can cause swelling of the, and then increases the pain.
No.
That was at a previous
Oh, right.
ear care.
No.
Because that's why I've always used olive oil.
On the nice guidelines, it actually says, if that doesn't work, it says to instill water and leave the patient for 15 minutes. But who's got time for that in a busy practice? But what does happen if you find it's not shifting on your first ear, leave that ear wet, go round to the other side, and then come back to your first ear, and invariably it will then budge. And 2 attempts, and then refer to ENT, which the new NICE guidelines.
2
advise.
attempts in the same day, or?
Oh no, if you bring them back. Yeah, no. I mean, you haven't got twice, you just wouldn't have achieved that anyway. I think that would be very sensible. No. Dry them as best you can, advise them to continue oiling, and then come back when you can fit them in a week, whatever. And if it doesn't budge, then say, I'm really sorry, but you're going to have to go to ENT. Yeah. I mean, the nurses at Rotherham who just do ear care, they will do instrumentation on some patients. They won't even bother with irrigation. If they're well oiled, they just remove the wax using a Jobson horn probe.
I've been shown, you know,
Yes.
and I used to do that, and then one of the nurses, I think it was last year or
Yeah.
so, went on a study day and they said, they're banned. And I said, but I was taught how to use
No.
it.
If you're taught how to
And it's
use
so
it,
much better than
and that's
swallowing
what the guidelines say, if you are, as long as you're trained, with the hands of somebody who's not trained, these are dangerous.
it. Yeah, oh yeah,
Yeah.
yeah.
Yeah. Any other questions?
Can I ask about
Yeah.
otitis media in a kiddie,
Yes.
like when they've perforated their eardrum and there's discharge coming
Yes,
out? How long do you tell them not to submerge their head in water for?
6 weeks.
6 weeks.
That's roughly how long it takes. Yeah, I usually just bring them back for a check in 6
Yeah.
weeks. And
So a lot of GPs don't even bother telling them not to.
no, I know,
submerge their heads.
they don't, no. And GPs, that's reminded me, when a patient sees a GP and their ears are full of wax, they go, oh, go and see the practice nurse. They haven't checked for any contraindications. You're the person doing the procedure to the patient. You'll be the one who is in trouble if you haven't checked. The GPs do not check there's any contraindications.
Is there an issue of healthcare assistants syringing ears?
Not if they've done the training.
And how much training do they have to do?
Well, the Rotherham course is a 2-day course, and then they have a competency booklet signed off by their mentor.
Right.
They have changed it recently. Courses I taught were you had to do a little case study, but they've just recently changed that, so they're no longer having to write a case study.
Because where I previously worked in Harrow, our healthcare assistants were syringing, they used the healthcare
Yes,
assistant course.
yes,
And they could syringe the ears if they'd been seen by a doctor or a nurse first.
exactly.
But where I'm working now,
Yes.
they're not letting them do it. And I said I wanted to find out if they want to.
Yes, if they go on the training course, they can do it. Yes,
Right.
yeah.
And it's not. Is
And
it
the mentor
accredited
comes
or-
with them on their first day, and they go through sort of, what's it when you delegate a task? Can't think of the word, but that they go through that with them because they can only do people who haven't got problems
Yeah.
and that the GP or mentor has said is safe to do. Yeah.
Are there any courses in run here? Does it count in the healthcare?
They don't do it as part of the health
No.
assistant course, but
No.
there are several courses that
Yeah.
are around,
Yeah.
which they
So I'll
can.
just speak to Owen.
Yeah.
Mm.
Yeah.
Yeah. But more and more tasks like that are being
Yeah, well,
given.
no, they want to do it. And I thought,
Yeah.
why can't you do it? So
Yeah.
I said
Yeah.
I'd ask.